Bone strength. A report by Dragon, Turnbull and Wells. What is bone strength? Bone strength broadly refers to the amount of bone mineral in a particular segment of bone tissue, which, in a clinical sense, is indicative of fracture, osteoporosis, osteomalacia, osteogenesis imperfecta, and other potential infirmities. Bone strength is predominantly attributed to cortical bone, or compact bone, the cortex layer, which accounts for 80% of total bone mass. At a cellular level, osteoclasts, which are multinucleated cells that resorb bone, osteoblasts, which secrete proteins that will form and regulate the organic matrix of bone, arising from bone marrow precursors, type 1 collagen, insoluble fibrous proteins synthesized from osteoblasts, alkaline phosphatase, responsible for bone mineralization, osteoconnectin, glycoproteins that bind to calcium, secreted by osteoblasts, thrombospondin 1, a widely secreted ligand which regulates bone homeostasis via effects of integrity, osteocalcin, bone mineralization and calcium ion homeostasis, often used as a marker for the bone formation process, secreted by osteoblasts, insulin-like growth factors, hydroxyapatite, and other salts.
Now on to the types of imaging techniques. So we have dual energy X-ray absorptiometry. This uses X-rays of two distinct energy peaks, and they are aimed at the patient. As the X-rays pass through the body, they are attenuated to a differing extent into different tissue types. This is the most common method for diagnosis of osteoporosis and broad fracture risk. We also have single energy X-ray absorptiometry. This is where a singular X-ray beam is used to measure bone density at peripheral sites. There is a single energy source and detector, and it's only limited to peripheral sites due to the need to submerge tissue in water. We also have dual X-ray absorptiometry and laser. This uses a laser and two types of X-ray energies to measure the thickness of three components: bone, lean soft tissue, and adipose tissue. The laser measurement enables patient-specific calculation to assess the impact from soft and adipose tissue on osteoporotic risk fracture. In quantitative computed tomography, this uses a standard X-ray computed tomography scanner with a calibration standard to produce BMD values from Hounsfield units. Solid phantoms are placed in a pad under the patient during image acquisition for calibration, which usually contains either calcium hydroxyapatite or potassium phosphate. In qualitative ultrasound, peripheral sites here are scanned in a small temperature-controlled warm water bath, and this eliminates the attenuation of ultrasound by air. This is conducted with a transducer of central frequency 0.5 MHz. The ultrasound wave of bipolar appearance is transmitted through the site and is thereafter detected by a receiving transducer. In single photon absorptiometry, a single energy photon beam is passed through bone and soft tissue to a detector. This quantifies the amount of mineral in its path. This enables differential estimation of the rates of loss from trabecular and cortical bone, which is indicative of bone mineral density. Dual photon absorptiometry uses a photon beam with two distinct energy peaks, one which is absorbed more by soft tissue and the other by bone. BMD is determined by comparing transmission of the two separate photoelectric energy peaks, which is commonly emitted by gadolinium-153. In digital X-ray radiogrammetry, the cortical width of three metacarpal bones in the non-dominant hand is assessed by a conventional radiograph, which is seen in the picture. The initial computer processing identifies anatomical landmarks, which are superimposed over a digitized image of the radiograph. In cone beam computed tomography, this is predominantly used to render 3D anatomical visualizations of the teeth, mandible, and surrounding facial skeleton. The 3D image is generated from a large series of 2D images, usually 150 to 200 high-res images in one rotation, and these emanate as a 360-degree spiral beam of X-rays. So when interpreting these results, we have the T-score, which is the number of standard deviations a patient's BMD differs from that of a healthy young adult of the same gender and ethnicity. More than -1 is considered normal, and less than -2.5 diagnoses osteoporosis. And we also have the Z-score, which is the number of standard deviations a patient's BMD differs from an average person of the same age, gender, and ethnicity. This differs from the T-score in that it determines whether additional reasons for bone loss besides aging are likely, such as glucocorticoid therapy, alcoholism, or hyperparathyroidism. Generally, BMD scanning is important in determining and assessing the disease course of a variety of skeletal infirmities, as well as evaluating vertebral deformity or previous fracture. Osteoporosis refers to impaired bone strength that predisposes to the development of fragility fractures. DXA is recommended. Osteomalacia refers to the softening of bones caused by deactivated bone mineralization, which is primarily due to inadequate levels and/or malabsorption of phosphate and calcium. A DXA scan is recommended. Bone mineralization and osteoblast differentiation are of notable concern with regard to BMD and osteogenesis imperfecta. A DXA scan is recommended. An abnormally high concentration of parathyroid hormone in the blood results in the weakening of bones through loss of calcium. The effect can be assessed via an SPA scan. Thyroid hormone has been found to increase bone turnover in vivo and stimulate bone resorption in vitro. Commonly associated with weight changes, hyperthyroidism can be assessed using DXA, as the two distinct energy peaks can be used to assess generic body composition. Using DXA, it has been shown that high rates of bone formation and resorption were seen in patients with high prolactin levels. DXA can thus be utilised as an imaging technique to suggest a patient has hyperprolactinemia. Celiac disease is characterised by a hypersensitivity to gluten, calcium malabsorption, hypocalcemia, and skeletal demineralisation. Investigations to measure BMD may be performed at diagnosis using DXA. As glucocorticoids are the treatment mainstay for such chronic inflammatory disease, consideration of their effects on bone remodelling should necessarily be taken into account. They have been shown to induce osteoblast apoptosis, reduce intestinal calcium absorption, and increase renal excretion of calcium. Thus, with an increased risk of BMD loss, DXA is the recommended screening method for inflammatory bowel disease. PBC is characterised by the inflammation of the intrahepatic bile ducts, which can lead to a loss of BMD. A DXA of the lumbar spine and proximal femur is the primary diagnostic tool for early detection. With MM, the overexpression of a ligand which has the mnemonic rank L may lead to excessive osteoclast activity and thus more resorbing of bone. As DXA may not be able to differentiate between myeloma-related osteoporosis from other causes of osteoporosis, it does, however, provide a BMD benchmark for monitoring the progression of intensive therapies. An early feature of rheumatoid arthritis is periarticular osteoporosis of the hand joints, which can be identified by DXA or DXR. Of notable concern for BMD, renal failure leads to changes in the circulating concentrations of phosphates, calcium, vitamin D, and parathyroid hormone. For assessment of the effects of renal failure on BMD, a peripheral QCT is more widely used than DXA due to its three-dimensional capabilities. Furthermore, since trabecular and cortical bone behave differently in response to an increase in parathyroid hormone activity, DXA is here incapable of distinguishing between the two types of bone.
DXA is considered the reference standard for determining and following osteoporosis. In addition, it can precisely measure both soft and hard tissue to a high degree of accuracy, and is considered a reliable method. However, due to expense, DXA is mainly used in laboratories only. DEXA is similar to DEXA in that it uses a single energy X-ray. Pros include the ability to measure both soft and hard tissue. A disadvantage of this technique is that the peripheral sites undergoing soft tissue examination need to be submerged. An advantage of DXL is the measurement of three tissue components, providing a better understanding of the patient. This laser approach enables a more patient-specific approach. An advantage of QCT is that it enables BMD measurements which can target patients with scoliosis, which can't occur in DEXA. However, this method is not considered safe for pregnant women. QUS is a relatively quick procedure when compared to other X-ray techniques, which makes it appealing to some. As well as being non-invasive and cheaper than X-ray, it does not produce radiation unlike X-ray. One disadvantage is the inability to measure peripheral sites. SPA is an accurate procedure. It is also relatively safe, as gadolinium-153 has a half-life of 60 days and only emits gamma radiation. However, it is a limitation in that the radioactive source gradually decays and must be replaced after time. DPA has a far greater accuracy in measuring BMD in skeletal bones when compared to SPA, partly due to a wider perceivable scope. This method, however, is not as capable as DEXA in discriminating fractures. DXR is a non-invasive technique and only requires a scan of 3 middle metacarpal bones to determine BMD, and is thus ideal for measuring BMD over time. A downside to this method, however, is its overall expense. CBCT produces a wide variety of views and angles, which can render 3D anatomical assessments of relationships quickly. This method is highly beneficial for dental surgeons for this reason. Once again, high expense is a drawback, and it is not recommended for pregnant women. To conclude, the most readily available and utilised modality for measuring BMD is the DXA scan. As the established gold standard, DXA is the most accurate method available for the diagnosis of osteoporosis and is also considered an accurate estimator of fracture risk. DXA is the recommended modality by the US Preventative Services Task Force, thus showing its wide range of applications in determining BMD infirmities.